All right. So I'm Josh Goodwin. I'm the doctor here at Regenexx Las Vegas. Going to give the webinar presentation today about different interventional spine treatment options that we provide here at Regenexx. Before I get talking too much, I just want to make sure that you can hear me. So if you can just type in the chat or the Q&A section that you can hear me, then we can get moving forward with the presentation. Make sure I'm talking loud enough. Okay, loud and clear. Okay, I got the go ahead. So I just wanted to make sure sometimes things can be on mute and I'll be talking and nobody will be able to hear me. Hopefully everybody can see the screen. This is what we're going to be going through here, just part of the presentation. As I mentioned, we're just talking about specifically spine issues and how we treat them at Regenexx. Some of you may have already had different types of treatments over the years if you've been dealing with any back or neck pain. So you might be familiar with some things. The whole goal of the webinar is just education. We do encourage questions. So those chat and Q&A areas, you can type in questions. I probably won't stop during the webinar to get to them until the end where we have a little Q&A time. Some of the questions might get answered as we go through the presentation. Really though, just kind of a summary of what we're going to go through, just an introduction to myself. We'll get into a little bit about, different causes of back pain, traditional treatment options, and then really focus on some of the things that we do here and kind of how we make decisions on. Okay, so people are saying that it keeps getting kind of cut up or that they can't hear me. Is anybody else having that problem? Sometimes it could be just an internet issue too. I'll kind of keep moving forward and we'll see if that clears up, or if somebody else is having the same issue, then we'll have to look a little bit more into it. But we'll get into some of the procedures that we do and how we decide who's a candidate, and just talk about some specific cases and just kind of basic examples of some of the things we see here in the clinic. As I mentioned, or maybe I didn't mention yet, but I'm about to mention, so I am a medical doctor. I did my medical school training at the University of New Mexico. That's where I grew up. I did move to Texas after that for residency training in physical medicine and rehabilitation. So that's a non-surgical field where we focus mainly on function, restoring function, reducing pain. A lot of it is orthopedic based, but I'm not a surgeon. So I am board certified in that. Fellowship trained in sports medicine, interventional spine. At that time, I did a little regenerative medicine using stem cells for low back pain and joints. In 2015, I joined Regenexx, who I've been with since then. I'm a co-author on the use of stem cells for low back pain related to disc issues. I've been here in Las Vegas since 2018. I was at the Iowa clinic for 3.5 years before moving here. So that's a little bit about my background. So just jumping into spine pain, hopefully that's why you guys are here, just to learn about. Some of this stuff you may not care about, but just to highlight that a lot of people deal with low back pain and neck pain, and it costs a lot of money for treatment, direct treatments, as well as lost work and wages. So we always need to continue to find better ways to help treat patients with back and neck pain. And people that need to go surgeries, it's an ever growing number of people getting surgeries as we age and those kind of things. But these are very expensive. Now, sometimes we're removed from the cost because of insurance, but these procedures can be very expensive, from fusions and disc surgeries. They do start to add up. And as you may or may not know, the more invasive the procedure, the more potential for complications. And so that starts to compound kind of how much things cost to get treated related to those complications. So in order to understand some of the different things that can be treated, we have to have a little basic understanding about what's going on in our spine. What is the anatomy? What's there? And then this helps us understand what can be causes of pain. And then once we understand what is potentially causing pain, we can develop different treatment plans. So in your neck, you have seven levels, 12 in your mid back, 5 in your lumbar, and then your sacrum and your tailbone. Some of these things can vary. So we have our vertebrae, which is our spinal column that helps protect the spinal cord. We have our disc. This is the cushion of our spine. We have joints. That's where one level connects to the next. And that is where people can have pain related to arthritis and those kind of things. We have our nerve canal and our spinal cord and nerve roots centrally, and then they exit to go out to different parts of our body. And so there's different things that can affect these different structures, which we'll talk about. But you can have bone injuries, you can have disc herniations. Disc herniations can pinch nerves. We can have joint arthritis. Bone spurs can project from the joint and pinch into the nerve. There's a lot of different things that can happen that can start to be associated with pain. Now, outside just the disc and the joints and the bone, we have other things that help keep our levels connected to each other through little cable systems. And these are our ligaments. So we have ligaments on the front and back of our vertebrae, behind the spinal canal, and towards the back of the spine. We have muscles that connect one level to the next. All of these things can be causes of pain, sometimes related to trauma, sometimes degenerative. And so some of the sources of pain, again, can be the bones through fractures or compression fractures or inflammation. We can have disc bulges or herniations. We can have tears of the disc. Our joints can become arthritic or injured, get inflammation of the joints. Your SI joint can cause pain. That's where your back meets your pelvis. We can have nerve compression and injury. We can have chemical irritation from tears and discs, muscle strains from traumas, whiplash, that kind of stuff, ligament injuries and looseness of ligaments secondary to degeneration, and that can create problems. Now, some of us may be really familiar with this because maybe you've gone through different treatments for your spine. Lifestyle modifications should be included in everybody's treatment plan. Exercise, weight loss, core strengthening, these can all help. Traditionally, people will be treated with medications. There's a lot of different types of medications, anti-inflammatories, your cortisone injections and oral medications, strong opiate pain pills like hydrocodone and morphine and Percocets, Lyrica, gabapentin for nerve pain, muscle relaxants, those kind of things. These are kind of the traditional things that are used. Some of them can be helpful, some of them come with risk. Chiropractic care, physical therapy can be helpful. We do recommend these for patients at times. Massage, acupuncture, different types of injections, which we'll talk a little bit more about, epidurals, radiofrequency ablation, spinal cord stimulators. And then obviously surgery, when a lot of these things fail or you have severe problems with significant nerve injury, sometimes people will go directly to surgery, depending on what the problem is. Now, it's good to look at even simple things like taking an ibuprofen does carry some risk, right? These types of medications are associated with heart attacks, strokes, kidney failure, kidney issues, stomach ulcers, bleeding, all these kind of things. So they're not to be taken lightly, even though they're one of the most commonly used medications for pain of, arthritis, whether it's the spine or the joints of the arms or legs. But they do carry risk. So the longer you take them, the more potential there is to have some adverse reactions. Opiates, like those pain medications, obviously these carry risk. They're typically used for more severe pain, but there's risk of dependency, intolerance, constipation, cognitive side effects. And so, if we don't have to be on those, we can find other ways to help with pain. It's better to avoid these when we can. As we mentioned, physical therapy is helpful. Some people say, well, I'm active already. Even high-level athletes need physical therapy to maintain their function. And so most people can benefit from this, even if your duties day-to-day are active and have you moving. Bracing can be helpful for when things are flared up. You don't want to rely on bracing forever, but sometimes when things are flared up, they can be helpful. If we get into the injections, just kind of more traditional injections, cortisone. So these are called corticosteroids or cortisone-based injections. Now, these are just strong anti-inflammatories, and they can help with pain related to inflammation, arthritis, inflamed nerves from irritation related to a disc herniation. But they do carry some level of risk as well. For diabetics, they're not necessarily safe, as they can increase your blood sugars. They can be associated with weight gain, flushing, anxiety, and they can be toxic to your tissue, especially with repeat dosing. And if you're anybody that's at risk for osteoporosis, they can increase your risk for related fractures from that. So epidural steroid injections are one of the most commonly done injections in the spine, close to 10 million done a year. Again, they do have some local toxic effect and some systemic effect. And as I mentioned, just one epidural steroid injection can increase the risk for fractures of the spine by up to 30% in women. So we got to be mindful of what the long-term consequences are of doing these types of injections. And what else can we use? What's healthier for the tissue, as opposed to injecting something that has a little bit of a toxic component to it. Your joint injections, those are your facets. Again, you can inject steroids there to help reduce pain and inflammation. But again, there's a little toxic effect to the cartilage cells of the joint, which, it's not what we want long-term. Once or twice, not a big deal, but over and over, maybe will create long-term problems. Now, there's other treatments for joint pain, and these are called radiofrequency ablations. This is essentially where they use a needle with a wire at the end of it to heat up a nerve thread that goes to your joint. And that basically scars down the nerve to disrupt the pain signals to the brain. While these can be very effective, I've done these procedures. They did help patients. The problem is that you're essentially killing a nerve that also goes to your back muscles and starts to disrupt how those muscles called the multifidus can react at that segment. And there's concern that maybe long-term that may or may not have some issues with control of that area and maybe lead to future acceleration of degeneration, which, people need to think about. And obviously spine surgeries don't come without their long list of potential complications. Many people get surgery and guess what? Still have pain. So they get this failed back surgery syndrome. I'm not sure if it's just kind of related to the fact that you have to create tissue damage to be able to put these things in. And failed surgery has been found in as high as 49% of patients. So it's pretty common. I've seen it. We probably all have known somebody that's had surgery that still has pain. You can get reherniations after cutting the disc herniation. You can, again, have chronic pain due to weakening of the muscles. That's something we see a lot on MRIs after somebody's had surgery, is your back muscles that help stabilize your back start to atrophy and turn into scar tissue. And a lot of people need additional surgery. So for example, a fusion, like what we see here, starts to load this problem, this level and this level. And then these start to wear down faster. So within a number of years, you start to get what we call adjacent segment degeneration. And that can lead to more surgeries. Infection, hardware breakage, paralysis. Sometimes you're dealing with nerves, blood clots, all those things. So if we can avoid the exposure to these risks with anything, it's worthwhile. Again, some people need surgeries, but sometimes we see that it maybe happens in situations when other things could have maybe helped. So our approach is tissue preservation. What can we do to help keep the tissue you have? We want to be less invasive and try to avoid the need for more invasive surgeries. And again, we want to repair or stabilize tissue rather than destroy or remove it. And we're basically taking advantage of natural healing mechanisms and components of our own bodies, which we'll talk more about, and delivering them through injections via X-ray or ultrasound to try to target tissues that have some degeneration, wear and tear, inflammation, those kind of things. Now we will learn that not everything is this isn't a good option for everybody in every condition. So Regenexx has been around since 2005, and we always started with innovation in the lab. We still have a big research and development center in Colorado, where we also have a registry and we track patients that we treat. All of the data we collect helps us guide our treatment decisions. Are you a good candidate? What conditions are responding? What conditions are not responding? And then we publish research about what we find here. And it's a continuous process of always trying to refine the whole process and our protocols. Again, we have training, we have our patient outcome database, we have research and development. We have more than 60 clinics worldwide. So we have different patents on processing and delivery of cells. We've treated more than 143,000 patients as an organization since 2005. And for spine conditions, currently tracking more than 15,000 patients. And as I mentioned, this is really just the evolution of medicine. As we learn more and we can take advantage of things that are found within our own bodies that maybe help improve the health, the strength of tissue, as opposed to cut it out, it just makes sense to do that. Just like surgeries are moving to more minimally invasive when possible, we can also try to take it a step further by just using needles when we can to try to target these degenerative tissues with the goal of preserving the tissue. Our approach is kind of comprehensive. It's not just looking at your spine as just a disc or a joint. These things work together. Disc problems can lead to nerve and joint problems. Muscle weakness can lead to overload of your joint and disc, which can then further degenerate and create nerve problems and pain. So these things function together, and we call them functional spinal units. And so that's how we approach our treatment, as opposed to just, oh, you have a disc bulge or you have degeneration and some arthritis. What else can be going on that can be a source of your pain? And so it's kind of a more comprehensive approach in trying to deal with what's going on. And so if we jump into the treatment options here and some of the things that we inject, again, what we do are needle injections and needle treatments to, in this case, the spine and the different components of the spine. Depending on what we're treating, depending on the severity, we may use different things. And so that's what this is highlighting. We use PRP, which we're going to learn about. We use something called platelet lysate. which we'll learn about. We use something called platelet-poor plasma and bone marrow concentrate stem cells. These are the things that we use to target spinal structures that are creating some problems. All of these cells are found within your own body, some within the blood, some within the bone marrow, and this is the areas that we extract them from to use their natural healing mechanisms. These are in your body to respond to injury, to help strengthen tissue. We all know that they work. We can break a bone, we heal our fracture. We can get a cut in our skin and we can grow new skin, right? So these things do have capacity to create healing within our bodies. And it's just about understanding what we can use, how concentrated does it have to be, and then how to deliver it to the problem area. So just to talk a little bit more about platelets, isolated platelets that are concentrated is called PRP, platelet-rich plasma. So platelets in your body help with clotting, but they also activate healing. So they're one of the first things that help when you break a bone, tear a muscle, tendon, cut your skin. They're one of the things that help promote the healing response where the problem is. They carry these different growth factors that are involved with different parts of the healing cascade. Growth factors that help with cell growth, new blood vessel generation, collagen production, new blood vessels, tissue repair, cell growth, wound healing, etc. So we can use these properties of these growth factors that are already found in your body, isolate them, concentrate them, and inject them into areas that have some degeneration or for some reason are creating irritation or inflammation. Now, we use PRP for mild to moderate arthritis of the spine, ligament sprains, and muscle injuries. We can also use them for mild disc pain or disc degeneration or small tears. And basically, they just help stimulate the tissue directly. They help improve the chemical environment. When things are inflamed, there's a change in the chemical makeup of the disc or the joint that can lead to further pain and further degeneration. So these help kind of restore the balance and the more healthy environment for these tissues to maintain themselves. The next thing we use are that solution called Platelet Lysate. Again, these are just collecting the growth factors. We extract them from the platelets, and it's only the growth factors. I think of this like an immediate release pill. It's anti-inflammatory, and we use it for irritated nerves. So instead of injecting cortisone around irritated nerves, we inject platelet lysate, which can reduce inflammation, but it has the added benefit of providing all these different properties to that region to help with healing, improving blood supply, stimulating the area. And most people that perform PRP cannot make platelet lysate. It's not made through the bedside centrifuge. You have to have a lab and different things to do that. And so we'll talk a little bit more about kind of what we do with that. There's something called platelet-poor plasma. This comes from the blood. You have your blood, your red blood cells, your platelets, the platelet-rich plasma, and then your platelet-poor plasma. And so there's some studies that show you can use this for muscle repair and muscle injuries. We've used it a lot for a muscle that starts to atrophy from chronic degeneration that's associated with chronic back pain. And so there's a couple studies looking at this and improving those tissues. And so we use this when we're trying to treat those deep back muscles that are involved with keeping your spine stable. And of course, last but not least, stem cells. This is what people hear about. We isolate them from your bone marrow, but you can find these cells throughout your body. They do respond to injured areas. They help kind of direct the tissue repair, kind of like a contractor at a construction site. they give the signal, they give the instruction for what tissue needs to do, and it can provide a lot of healing and proteins and different cellular components to the injured cell to help kind of revive it. And when you check these cells in the lab, you see that they can transform into different tissues. And so that gives them the added benefit when you have kind of more significant problems going on. So in the spine, we use these for disc tears, discs that are painful that have some degeneration, more moderate to severe joint arthritis. We do not use these around the nerves typically. We exclusively use the platelet lysate in those areas. It just seems to be the most effective around that. So just a quick summary. Again, injection-based, we use PRP, which comes from your blood, and we use it for these milder conditions. Platelet lysate also comes from the blood. We use these around nerves. The platelet-poor plasma we typically use for muscle treatment. The bone marrow concentrate stem cells and all the other components that come there for more severe joint arthritis, more moderate disc degeneration, and disc tears. If you have complete disc height loss or more than 50%, we don't typically try to go after the disc. It does have some limitations in what it can respond depending on its status. And so we'll talk more about how we make those decisions, but it's important to know that this doesn't help with everything. Notice I didn't say that we could get rid of bone spurs or anything like that. These things, if a bone spur is completely pinching a nerve, these injections aren't going to be able to do anything about that in regards to changing the bone spur. It may help with irritation, but it's not going to be able to change certain things going on in the spine. And so again, just to kind of summarize, just to make sure people get it, we can do what we call our PL disc procedure. This is essentially when you have like a sciatica or an irritated nerve in the neck, where we're using that platelet growth factors. If you have some disc degeneration, we do something called our DDD procedure, where we use PRP to inject around the discs or into the disc, joints, ligaments, things that stabilize the spine. If it's a little more severe, we use the cells from the bone marrow. Now, we do have a clinic in the Grand Cayman Islands that allows us to grow out your stem cells to higher levels. That's not available in the US, at least not at this point, hopefully in the future. But that seems to be a little more successful if you have little disc herniations that are irritating the nerve, that are having a hard time shrinking back. This may be something that could be helpful. And so just going over some of the things that we've seen as far as data, we did a little study looking at people that have sciatica or nerve irritation, and they were going to get an epidural. Some people got steroids, some people got platelet lysate, the growth factors. And when followed, people that got platelet lysate did extremely better compared to the steroid group. This was the functional improvements from baseline. It took less injections. So here's some data showing that instead of using cortisone-based treatment that is a little toxic over time, the platelet lysate is even more effective than that, and is more healthy to the body. We do have a phase 2 trial approved to try to get the technology that we use with growing out people's stem cells in the Cayman Islands available in the US. Hopefully that will be sometime in the future. There was a study using stem cells for disc pain. Now up to 5-year follow-up, 81% of the patients avoided surgery. I think this has even followed up to 5 years. The average reduction in pain was 70%, and function improved by 64%. So there is data showing that using your bone marrow to inject discs, depending on how bad they are, again, depends on how bad they are, people can see significant improvement. Also with PRP, there's studies that were double-blinded that looked at improving pain from discs in patients, and at 1 year, people that received PRP still had significant improvement. So again, just showing that these can be helpful for some of these areas. We did a study as an organization. These are some of the doctors that were in Colorado about treating all of those different units of your spine, the ligaments, the joints, the disc, and the nerve spaces, and treating that comprehensively. And at 2-year follow-up, those patients demonstrated significant clinical improvement with that process. So it just kind of proves that treating the whole unit is sometimes better than just going after one individual thing. These are some of the other studies that we've, as an organization, have published. Disc issues, again, with platelet lysate right here, treating the disc, treating instability of the upper neck. And these are all on our website. Again, we have our registry data. The combination of neck and low back, it's close to 15,000 patients. You can go on the regenexx.com website to look at this, to look at function, pain improvement over a 4-year time frame. So it's just a little bit about that. You know, it's important to just be able to sit back and when you're deciding what you want to do to treat your back, it's good to know what all the different options are, okay? Not every treatment is the right treatment for everybody. Everybody's situation is unique. Success rates can vary based on your unique characteristics. And this next portion of our talk is going to kind of go into that. So part of the decision making about if what we do would be beneficial happens when we do an evaluation. This is when we can spend at least an hour understanding what the problem is, what your medical history is, what your imaging shows, your MRI, your CT scan, perform a physical exam to see if you're having issues with nerve pain or weakness or nerve damage, and kind of help put the picture together as far as what's creating the problem. And this is how we develop our customized treatment plan and have a discussion about treatment options. Is what we do beneficial? Do you actually need surgery? Is maybe physical therapy a better way to go now? And then we decide, are you a high responder, a moderate, or a low responder? And again, that gets into what does the imaging show? What does your exam show? Not everybody's a good candidate. So this is how we determine that. And so I just wanted to just kind of provide just a very basic example of, you know, maybe how somebody would present and what we would do in a patient that just had some nerve irritation in the back. So say this patient came in, they could be you, and you have radiating pain with numbness and tingling to the front part of your left thigh and knee. When we look at your MRI, it shows that you have a disc herniation at this level that corresponds to this distribution. The other parts of your spine look good. No disc loss, no joint arthritis, no muscle atrophy. We would consider this patient a high responder. Some people do need more than one treatment, and we would use platelet lysate to help treat the nerve irritation and to inject behind the disc herniation to stimulate your body's response to that area. That's how we would approach this. So what's involved? It's a 1-day procedure. We do a blood draw to be able to, in our lab, isolate those growth factors. And we do have to remember that the processing is very important. Being able to adjust dose, being able to actually produce platelet lysate or high concentration PRP is important for the outcome. And so having a lab where we can do that and customize things That's what helps give people a better chance for improvement. We always do injections under ultrasound or x-ray. Most spine injections are under x-ray. This is an example of an injection around the nerve space at the L4 level. This is where the nerve exits. This is the needle and the contrast flowing. So we have to make sure it's going to go where we want it to go. And you have to use imaging for that. Now, another example, this is a person that has low back pain and some sciatica down the leg to the big toe. They also have some muscle tightness and some tightness in the back of their leg. Now, their MRI shows a lot more findings. They have more moderate herniation at a different level. The disc is somewhat reduced, but they have no disc tear. The disc is touching the nerve, and they also have joint arthritis and some muscle loss. This is somebody that gets our what we call our degenerative disc disease protocol. This is where we use PRP. We inject the joints and the ligaments where the disc is reduced in size. We use platelet lysate for the nerve irritation. And we use the platelet-poor plasma for the muscle atrophy. These muscles help control your spine segments. When they're weak, you have more motion, and that can lead to more pain and irritation. Again, we're treating the functional unit, as I mentioned earlier, not just a disc bulge. You have other things going on in this example that also need to be treated. So it tends to be very comprehensive, a lot of different injections to target these different areas. The procedure day is very similar. The blood draw might be a little greater because we have to treat more areas. And all this is done in the same day. And this is an example of some of the different things that we may be looking at with imaging. We have the nerve space injection for the nerve irritation, for that pain radiating down the leg. We're injecting the joints that have little arthritis. We're injecting the ligaments that connect and help stabilize these different segments. And then this is an ultrasound injecting those deep multifidus muscles of the back that help with spinal control. And this is how we go about treating those different areas. Now, if we take it the next level, now somebody that needs stem cell and also a disc treatment, low back pain, maybe some radiating pain, but they have a lot of difficulty with sitting for prolonged periods or bending forward. We see some disc problems. We see a little bit of reduced height, but not severe. There is a tear. You have a little nerve pressure, more moderate to severe arthritis, and more moderate atrophy of the multifidus. This is when we start to use the bone marrow stem cells. We always combine it with PRP, and we would probably inject the disc. We would also use the stem cell from bone marrow and PRP for the joints. We could treat with PRP to the ligaments, the PPP for the muscles, and the platelet lysate for the nerve irritation. So you can see we need multiple products to be able to do this. That can only be done in the lab that we have, because you need to be able to customize these different things. These things aren't created by a bedside centrifuge that most clinics have. Now, again, this is a one-day procedure. The bone marrow aspiration takes about 30 to 40 minutes, and you can use IV sedation. We also get blood. As I said, we need some of the PRP and that platelet lysate. And again, everything's done under x-ray. And so some people get very nervous about the bone marrow. Most people do really well. I would say 9 out of 10 patients do really well. Minimal pain, mild pain. IV sedation helps with that, obviously. But it's a very safe procedure. There's large studies looking at safety. But this is where we go. This is an example of all the different things we'll be looking at with treatment. We would need to do the bone marrow aspiration from the pelvis. And then once we isolate and get all the things we need, then we can treat the spine. We can treat around the nerves, the ligaments, the joints, this is an injection into the disc. And then this again is an injection into the muscles. And so this is a very comprehensive treatment and how we go about treating these different conditions. So after these spinal injections, people do get some pain and soreness and some stiffness for about 2 to 3 days. If you had the disc injected, it's actually probably a little bit longer than that. Most people will benefit from some physical therapy. Sometimes we will give a brace. People do get maybe a few days of some pain medications. And we just ask people to modify activity for the first couple of weeks, more low impact exercise as opposed to getting right into heavy lifting or high impact activities. And again, disc injections can be painful for a little bit longer. And then we track and we see people back every 6 weeks to 3 months. Some people do need more than one treatment over time. I'd probably say at least 30% of spine patients that have just degeneration need more than one treatment over time. But we never make that decision until we treat and we reevaluate your response. We have to see that we're getting better, right? Not everybody's going to respond. Not everybody gets 100% improvement, but we got to be able to make decisions based on your specific response. Even though we do the evaluation, we look at the registry, we try to understand what our best guess is for you, it's hard for us to predict exactly how much improvement you're going to get. And just an example, I have some others on my computer, but these are just a couple I included. This one showing an MRI showing a big herniation at the L4. This is a post-MRI, I think 6 months later after a couple of treatments with the platelet lysate and treating the functional units. The disc is preserved, mainly just a big disc herniation. This is one that had stem cells into the disc for these tears, and post-MRI showing that those tears had resolved. So similar things are done in the neck. We don't do as much disc injections in the neck. I don't really do too many of those. Other people do a little bit. Most of the disc treatments in the low back, but in the neck, we still treat the joints, the muscles, the ligaments around the nerve, the nerve space, all that stuff, and can have similar success. So with all that, I don't see that anybody's written down any questions in the chat or the Q&A section. That's just getting through that very quickly, a lot of information. If there's any questions, feel free to write into the chat and the Q&A, and we can spend some time going over that. I'll try to think of some common questions. Some of it we mentioned. Preparation for the injections is typically, we don't want people taking ibuprofen or Aleve for at least 5 days prior to the procedure and up to 2 weeks after. That's just because they can affect platelets and your response to them. If people are on strong blood thinners, they need to get off. We do need an MRI and or CT scan to be able to understand if we can treat you at all. X-rays or ultrasound don't give us enough information. You can treat multiple segments in the spine at one time. So if you have 2, 3 disc levels or joint arthritic levels, you can treat those all in one session. Just takes more injections. Let's think. The risks of the injections are no different than if you've had a steroid injection in the spine, a joint injection, any of those things. There's no added risk. There's always a risk for infection, bleeding, nerve irritation. Disc injections carry a little higher rate of infection. Even though we've done some things to help reduce that, it's never zero. So those are always things to talk about in regards to risk-benefit ratios. We have treated people that have had prior back surgery, so that doesn't necessarily mean you can't do it. Bone spurs don't respond as well and can reduce the overall likelihood of success. Very severe stenosis, meaning the nerve space is very, very tight. Sometimes we can't treat because it's too risky. more so in the neck if it gets to be severe. If you're adding more fluid to a very tight space, then you put people at risk for more irritation. Let's see, any questions that you guys have? Nobody's written anything yet, so I'm just kind of giving you guys a second if there's anything that comes up. Well, I'll just kind of go over this part. Melissa Wright is our patient coordinator. This is her email and her phone number. If you guys needed more information, wanting to schedule a consultation, or if want to send in your imaging to see if it's even worthwhile to do an in-person or a Zoom consultation, then you can get information from her, and she can help kind of guide you. She's been working with us for a long time, so she can answer most of people's questions. But we breezed through that relatively quickly. It's been almost an hour already. Nobody's asking questions. I think we've gone through most of it that I can think of, some of the more common things. I'll let you guys get back to your evening. I appreciate your time. Again, reach out if you have more questions or want to be seen here in the clinic. I hope you guys have a good evening. Thank you. Oh, we got one. Are there limitations on how many sites you can treat, determined by how much marrow you can aspirate? Yeah, sometimes. I think for the spine, most of the structures can only take small amounts of volume. So if you're only treating the spine and not trying to treat like a knee and a hip or a shoulder, then we don't tend to have too much limitations in the spine. Now, if you needed neck and low back and multiple joints, the amount of volume you have related to the bone marrow aspiration and the cell counts may not be there. But again, like your joints in your spine can hold, a half cc to a full cc. Your discs, we don't really inject more than 1 to 2 cc's. Don't typically like to inject more than 1 to 2 discs at a time, just because it can be very uncomfortable after the procedure. So those are things that we talk about if you come in for consultation and ever decide to move forward with the procedure. Yeah, so it says if there's no disc left, is that untreatable? No, not necessarily. In the sense that if you're meaning treatable by regrowing your disc, then yeah, we cannot regrow your disc. Discs don't necessarily, we haven't seen them regrow. Specifically, if there's no disc left, it's hard to even get a needle in there. But what happens when your disc reduces, it starts to overload your joints. It can irritate the nerves, and you get a little instability at that segment, which then overstresses the muscles. So basically, we treat it by trying to stabilize that segment. You treat the joints that are overloaded. You can treat around the irritated nerves to reduce irritation, and you can treat the muscles and ligaments, trying to reinforce that segment, and that can go a long way with helping symptoms. In those cases, sometimes it takes multiple treatments, but it doesn't mean that you can't derive benefit, even though the disc is significantly reduced. Again, we don't tend to go after to inject the disc in those situations because it doesn't seem to really provide all that much extra benefit. But you can treat the functional spinal unit, and that can create some good improvement in symptoms. I hope that makes sense. Yeah. Well, for those things, some people will get a fusion, and then we've treated levels above the fusion or below the fusion, so just because we know that, as things are, when there's adjacent wear and tear, people get fused and the levels above and below start to break down. And then we've treated a lot of those patients to try to keep those levels stable, reduce irritation of those segments. And we've had some success with treating above or below fusions. So yeah, that's definitely an option for people. Yeah, exactly. Yeah, try to prevent the escalation of fusions, which sometimes is this merry-go-round. Sometimes it takes a long time to get there, but a lot of people do start to break down the tissues above and below, and that can lead to more surgery in a lot of cases. And so if we can do what we do to preserve the tissues above and below, keep your strength as much as you can, keep your weight stable, be healthy otherwise, and sometimes injection therapies can help keep things going well as well. Awesome. Yeah, no problem. All right. Well, I think that's the end of the questions there. I will let you guys get to your evening. Thank you for your time. Again, reach out to us or to Melissa if there's anything that comes up. Have a good evening.